Good morning, good afternoon, and good evening from wherever you are joining us from. Welcome, everyone, and thank you to those joining us live and to those listening in afterwards. I'd like to warmly welcome our listeners and our guests in this session. My name is Dalia Badis, and I am the lead for provision and partnerships at the International Pharmaceutical Federation, FIP. It is my great pleasure to facilitate today's webinar along with my colleagues on the call. FIP's vision is a world where everyone benefits from access to safe, effective, quality, and affordable medicines and health technologies. Our mission is to support global health by enabling the advancement of pharmaceutical practice, sciences, and education. We are pleased to be delivering this event entitled Uncovering Our Implicit Biases to Advance Patient Care, an Introduction for Pharmacists. This is a special event coordinated under the FIP COVID-19 digital program, COVID-19 Collaborating Through the Pandemic, Working and Learning Together. We know that the world's pharmacy team is fighting COVID-19 everywhere, working closely with each other and with other healthcare workers, and often putting their lives at risk to protect and care for patients and the public during these times. Diseases like COVID-19 infection can make any of us sick, regardless of race, gender, or ethnicity. And one way we as healthcare providers can ensure that we are providing the highest quality of care for all people and society is by becoming more aware of our own biases and taking action to address those. Our esteemed speakers today will help us unpack the concept of implicit bias during this session. But first, some housekeeping reminders from FIP. Please note this event will be recorded, live streamed on YouTube, and will be available later on for viewing at www.events.fip.org. To all those listening in, please feel free to send in your questions through the Q&A box, and we will be picking those up throughout today's session. I would like to mention that you can watch previous episodes in this program and other programs via our website on events.fip.org. Finally, if you are not a member of FIP yet, let me take this opportunity to encourage you to join our wonderful federation, to avail of the many benefits such as these wonderful events and lots of resources. And that way you can truly be part of the pharmacist's voice worldwide. And now I would like to introduce the moderator of the webinar, my colleague and friend, Dr. Mohammed Amin. Mohammed is an associate professor at the Beirut Arab University in Beirut, Lebanon. Mohammed is a pharmacist by training, and he received his PhD from the University of Wisconsin in the US. His research involves clinicians, students, and patients in the US, Egypt, Pakistan, and Lebanon. He served as a faculty member at pharmacy schools in Egypt, the US, and Lebanon. He is an associate editor for RSAP and a member of the academic pharmacy section at FIP. Welcome, Mohammed, and I turn the floor to you. Thank you so much.
Hello, and thank you, Dalia, for introducing me. All right, we have a great program for you guys today, and we're very excited to have to see participants from all around the globe. So we're going to start with a brief introduction and then an overview on implicit bias, what it is, and then our panelists towards the end, they're going to introduce strategies for managing bias and macro level, micro level. And then we're going to have an exciting interactive activity that our panelists are going to introduce. And then our group is going to reconvene for Q&A. Please use the Q&A box to type your questions. And then we're going to end up with conclusions. At the end of this session, these are our learning objectives. We want to understand what implicit bias is and what its impact is on terms of health disparities in care. want to discuss the impact of implicit unconscious bias and how it affects our relationships with our patients, with our students, as well as our colleagues and other health professionals. We want to take the time to identify and reflect on biases and perhaps also use the activity we have towards the end to do that. We're going to end up by listing and discussing strategies to mitigate unconscious bias in terms of pharmacy practice and education to improve patient-centered care. All right, I want to now take the time to introduce our two great speakers whom we have today. So I'm going to start by Dr. Sally Arif. She is the National Chair for the American Association of Colleges of Pharmacy, Health Disparities, and Cultural Competency Special Interest Group. As an associate professor at Midwestern University in the United States, she's had the chance to reach thousands of healthcare trainees through her lectures, workshops, and simulation activities focused on enhancing students' cultural sensitivity, awareness of implicit bias, and social determinants of health. Dr. Arif is the founding advisor of MEPA, the Middle Eastern Pharmacists Association in the United States. This is a pharmacy student-led organization that has offered free health screenings and educational classes to refugees and immigrants patients. Dr. Arif is also affiliated faculty with the Chicago Center for Community Health Equity and has provided numerous diversity and inclusion trainings to healthcare professionals at her clinical practice site. So welcome, Dr. Sally. And then we also have Dr. Jack Collins. Dr. Collins is a practicing community pharmacist and postdoctoral research associate at the Sydney Pharmacy Schools within the Faculty of Medicine and Health. Dr. Collins completed his PhD in 2020 in the area of community pharmacy, facilitation of consumer self-care. He was awarded the Bachelor of Pharmacy with first-class honors and the University Medal from the University of Sydney in 2015. He was the 2018 recipient of the International Pharmaceutical Federation Young Pharmacist Grant for Professional Innovation for his important work on implicit bias in pharmacists. So welcome, Dr. Sally and Dr. Arif, Dr. Collins. Passing the torch to you, Sally.
Thank you so much, Dr. Amin, for that wonderful welcome. Jack and I are very excited to be with all of you today, and to kind of warm us up to this topic of implicit bias, we're going to start with a riddle. So go ahead and take a minute and read through this riddle and see if you can come up with the answer. Okay, so feel free to put into the chat box, who is the surgeon? And if you're still baffled or wondering, you are not alone. This riddle we did not write, but has been out there for some time. And 40 to 70% of readers of this riddle often don't come to the quick answer that was intended, which is the surgeon is the mother. And while often, you know, if we ask the direct question, can women be surgeons? Emphatically, most of us would say, of course they can. But when reading in this context, often our unconscious bias that might have associations with gender roles, filling certain types of professions, might block us from seeing that as a possible quick answer. So this is just to kind of show us that our unconscious biases are often at play and do not necessarily align with our explicit understanding or belief systems. So I want to also kind of put out there a disclaimer. When we're talking about implicit biases, a lot of feelings tend to come up. So we're going to lean in to any discomfort that might come up for us. I want you to think about that as you are going through some of the content with us today. We like to call this our stretch zone, where we learn the most. So we don't want to necessarily have you feel super comfortable as we talk about some of these topics. We want you to be pondering, wondering, challenging some of your thought systems, because that's, again, where that stretch zone of growth happens. We also ask you to do one more thing for us, and promise we'll come back to this at the end of the webinar. But if you're wearing a watch, a ring, a bracelet, go ahead and at this time move it to another finger, the other wrist, and leave it there for the rest of this webinar. And we'll come back to why we're doing this at the end as well. Okay, so as was mentioned, I've done a lot of these seminars and workshops around bias in healthcare, and often there's this knee-jerk reaction from healthcare professionals I've talked with that implicit bias doesn't relate to me because I am not a racist, I am not a sexist, I have friends from many different backgrounds, I celebrate diversity. And what we're here to kind of set the tone for is when we talk about implicit biases, these are unconscious biases that often are not aligned, like we said, with our explicit views or political views or social views around diversity. These are often what the scientific evidence shows us is often in the background of our minds that we don't even see at play sometimes with our decision making and actions in the world. And so it might seem a little unsettling to sometimes our ego to think that we all carry implicit biases, but our goal today is to show you that they don't necessarily equate with explicit biases. They're very different, and that they can influence our decisions as healthcare professionals. So let's start at the beginning of what a bias is. So when we think about bias, we're evaluating one group versus another. And we're making some decision points around those two groups when comparing them. Explicitly, we might be aware if we notice differences or preferences. And that's, again, not what we're talking about today. Implicitly is what we're kind of getting at, which is these kind of subconscious or unconscious cognitive biases that we carry that are automatic, unintentional, often deeply ingrained, and are based off of associations that we've learned over our lifetimes. And so surfacing these biases is really important so that we can make sure that they aren't influencing negatively any decisions or behaviors that we might have with our patients or one another. Cognitive biases, again, force us to make assumptions or inferences about others. And as Verna Myers, who has an amazing TED Talk, if you haven't checked it out, she's a social activist, lawyer, and she really does a lot of work around diversity and inclusion, put it very nicely in her TED Talk. The implicit biases are the stories we make up about people before we actually even know who they are. And the reason for this, if we're going to get into the neuroscience, is that our brains are constantly taking in millions of pieces of information through our senses every single minute. But we're only consciously aware of a very small fraction of this information. And that causes us to go into mental shortcuts in order to be efficient in our everyday lives. We're also hardwired as humans to want to make meaning out of everything we see or sense around us. And that means often that we go off of our lived experiences. We like to categorize things as in-group, out-group, familiar, not familiar, safe, not safe. And that this also applies to a lot of social identities around us. For example, racial biases are known to reside also in our unconscious network. And the messaging around us in our environment can often be framed to speak to this unconscious associations that we're forming. Let me give you an example of this. So if you look on the screen right now, you're going to see two very arbitrary shapes. They should mean very little to you because, again, they shouldn't necessarily mount an emotional response, but you're seeing them through your senses. If I asked you to name one of these shapes boba and one of these shapes Kiki, which one would you name which? Okay, you got it? So if I had to guess, and I'm not a mind reader, but this is probably what you did. And this is an experiment that was actually first done in 1929 by a German-American psychologist named Wolfgang Kohler. And this has now been replicated around the world since 1929 in many different cultures, across many different languages. And over 90% of participants will name these arbitrary shapes the same way, which shows, again, our hardwiring to want to label things, to want to make meaning of things, even when it comes to sound recognition and wanting to assign it to a particular shape. Now imagine how this plays out when we're seeing individuals in front of us, which is a much more complicated situation. Going back to the neurological origins of implicit bias, what's at play when we're doing this are two systems that are housed in our limbic system. System one is our fast thinking brains, which processes information around us very quickly and often based off of past context or learning situations we've been part of. And this is often rooted in our amygdala, which is responsible for our quick emotional responses. This is where we are kept safe. Animals have the amygdala firing constantly too, through system one, to again have a mounted response when we're in a situation where we need to make a quick decision or we're supposed to act quickly. System two is the slow thinking process, and this works 100 times slower than system one, but this is housed in our prefrontal cortex. And this is where we do a lot more of our objective, logical, rational thinking. Unfortunately, often system two is not at play when we're at work because we're making these mental shortcuts to get our jobs done. And that includes taking care of our patients or working with our colleagues or students. This system works because it, again, helps us be efficient in the world around us. So if you see someone handing you the drink that you just ordered at the coffee shop and they're smiling at you, often most of us, despite what cultures we might come from, are going to immediately reach over without thinking twice and take our drink without thinking, oh, is this person up to no good? Or could I be in danger right now? Because system one has taught us a smile is friendly, or system one has told us, well, this is what happens in this setting. You don't need to think about this. Same system is at play if we see someone like this on the right-hand side of the screen walking down a dark alley. We're going to probably be running the opposite direction before we even think twice, right? Because we've learned through context in our lives that someone holding a sharp object like this might be dangerous. This might look, concerning to us. And so we're not going to activate system two thinking, which would be more objective and say, well, is this person having a bad day? Should I maybe pause here and ask if they need help? I wonder what they're doing with this knife, right? We're not going to be doing that because, again, our brains are formulated in a way to keep us safe. Unfortunately, these systems are going to be at play when we're busy at work as well. And so these biases, these automatic triggers, are going to cause us to make quick judgments, assessments of people around us based off of our past personal experiences. And it's based also off of pattern recognition. Even seeing someone's facial or body expressions is going to mount a response in us based off of past experiences. So if I'm working and it's been a busy day at the pharmacy and I see a patient walk in and they look concerned and it's 5 minutes till closing and I'm tired from a 10-hour shift, and I'm going to immediately start to have a response, even though I'm a well-intentioned individual who wants to help people in my profession, I'm going to automatically start to assume that this person is going to take too much time. They look frazzled. They have a lot of prescriptions with them. They might have a lot of questions for me. And so how is that going to, again, manifest when system one is going to be mounted in my response in that moment as a healthcare professional? This idea in cognitive biases called diagnosis bias is the propensity for us as individuals to want to label people, ideas, or things based off of that initial response or opinion we have about them. And what's so fascinating about this is that it's often hard for us to change our minds about something that we've already established as the norm. So let me give you another arbitrary kind of example of this from the literature. So Dr. Edelman from MIT did this experiment where he asked individuals in the study to look at box A and box B on the screen. And he asked them, are box A and box B the same color of gray? Now I'll ask you the same question. Do you see them as the same color of gray? Most participants would say, absolutely not. They're very different shades of gray. Now, this is an optical illusion. If I actually prove to you, I am not making this up, A and B are, and I'll blow it up here, the same exact color of gray. How many of us feel that this is true? Now, some of you might still be thinking, no, there's no way that those are the same color of gray. I've learned in my lifetime that a checkerboard is opposing shades, right, or different colors. And so this goes to this idea that we also have this tendency in our cognitive biases for confirmation bias, that we are constantly, unconsciously looking or seeking for information that confirms pre-existing belief systems that we already have, even when we're given evidence that exists to the contrary. Now, imagine this when it comes to the work we do. If we're mounting a response that we want to see errors because we expect errors to happen from a particular individual we work with, or we might expect a particular individual to behave in a certain way, we're going to look for that behavior unconsciously without even recognizing that we're doing so. And when we're actually shown evidence to the contrary, it's very difficult for us to believe that because of confirmation bias. Now, you might be wondering, well, again, I don't think that this happens to a lot of healthcare professionals. We've taken oaths to care for our patients impartially. We are fair. We've gone into our professions because we want to help others. We don't see, differences. But what the research shows is that implicit biases are just as likely in healthcare professionals as they are in our general population around us. And what this meta-analysis recently showed us was that they're likely to influence our ability to diagnose, our ability to treat patients in a fair manner. And the findings of this meta-analysis also showed that healthcare professionals really need to start to address the role of implicit bias and how it manifests in health inequities. And that's part of the reason why some of these trainings are happening around the world around implicit bias, and hopefully why we're doing sessions like this today. We also have started to study this in pharmacy education. And so if you're involved in a school of pharmacy, or you might be precepting students on their experiential experiences, you should be aware that there is studies out there that you can read about that really show that pharmacy students do have reflections around implicit associations. Often they feel that they, similar to practicing pharmacists, don't have implicit biases at play. And so this is why, again, the pharmacy education system is also around the world starting to put an emphasis on diversity education, as well as specifically implicit bias training. I'm going to pass it along to my colleague, Jack, to talk about this in the pharmacist realm.
Thanks, Sally. Hi, everyone. You might recognize the first author on this paper. So this is the work that I got to do with the support of FIP. And this was really an exploratory study, the first piece of work in practicing pharmacists to look at implicit bias. And although it's just exploratory, I can also confirm that it looks like we have it ourselves as well. So I sent actors of 4 different races into community pharmacies. So I had a white actor, a South Asian actor, an East Asian actor, and a Middle Eastern actor. And when we analysed the way that the patients were treated and how they communicated with the pharmacists, this is all covert, so the pharmacist didn't know that they were dealing with an actor. We found that the white person was treated better in terms of the tone that the pharmacist engaged in conversation with. So we can see that even though they were all just going in with regular over-the-counter requests, certainly that there was some evidence or suggestion that implicit bias was also present in community pharmacists.
Thank you, Jack. So what we want to leave you with at this moment of the session is that implicit biases don't necessarily make us automatically discriminatory or prejudiced towards other. It just makes us human, because we all have the tendency to do this. And so part of this goal today is to really communicate that it's something that we want to talk about. It's something that we want to have conversations around and dialogue around, and really remove any sort of guilt or shame around, so that we can start to surface our implicit biases and really have honest, constructive conversations around how to mitigate our implicit biases. The other part of this is the social impact of these mental shortcuts because of implicit biases, leading to us having stereotypes or generalizations around particular groups of individuals in the healthcare realm. And the goal here is that we really want to center around the idea that these social impacts can lead to not just stereotyping in a negative way, but also microaggressions in the workplace. Now, microaggressions is a word that many of us maybe have not been familiar with. So microaggressions are often defined as a brief, indirect, subtle, or unintentional verbal, behavioral discrimination that communicates derogatory or negative slights against a member of a marginalized group. So sometimes these can come off as a joke. Sometimes these comments can seem very almost, they're meant in a complimentary way, but they land very harmful to the individual that they're being said to. And so I want you to kind of think about these microaggressions and how maybe you personally have felt some of these even in your places of work or in your practice settings. So I want us to kind of do a quick poll at this point. And again, this is anonymous, but with this poll that you'll see pop up on your screen now, I want you to answer, have you ever been the witness to or the recipient of a microaggression at work? And I'm not seeing the poll. Okay, there it goes. So go ahead and answer this question. Have you been the witness to or the recipient of a microaggression comment at work? And if you're not sure, you can answer that way as well. Okay, so as you can see from the poll responses, many individuals might not be sure, but we also see over half of our participants today saying, yes, we have, which really speaks to, again, the importance of talking about implicit biases, which often are the root of some of these microaggressive comments. And when microaggressive comments continuously happen to a group that might be marginalized in society, and that might include ourselves with our particular identities at work, it can be very harmful and toxic to the work environment. It could cause people to disengage, to lose their passion for what they're doing, to not want to contribute to the projects that are going on. And so as leaders in the workforce, if you happen to have a status or position as a leader, it's important to have conversations around microaggressions so that we create a culture of belonging and no tolerance kind of policy for these types of things occurring. As we can see from some of the comments and just the fact that a lot of us experience bias playing out in our workplaces, biases can influence many factors of our lives. It can definitely influence how we perceive people around us, the reality of the world around us, our attitudes towards certain individuals, our behaviors. So this might be how receptive we are to or friendly we are to certain groups of individuals, how much attention we give to certain individuals, even how much we provide active listening to individuals. And again, not just our patients, but our colleagues and our students. And then lastly, our empathy level even. And we know as pharmacists how important it is and how often we measure empathy and in our workplaces with patient care. But if we know biases can influence how much we comfort certain individuals, that can be really detrimental to developing a trust relationship with our patients. And we titled this session today on how implicit biases can influence patient-centered care. So it's important for us to define what we mean by patient-centered care. What we know patient-centered care to be is a focus on the patient themselves as the individual that's at the table helping us make decisions towards their care needs and their goals. And so part of patient care is empowering patients to be active participants in their care. How do we really do this or achieve this when we know that biases might be playing out in the background? We're not really giving a fair shot to our patients to be an active participant if we're already clouding the situation with some of our fast thinking biases in the care. And the consequences we've seen in literature around this on treatment and patient care is not only failures in patient-centered care because of bias, but also interpersonal treatment. So patients might be wondering, does my pharmacist even really care about me? And not just me from a biomedical lens, but from a larger lens, a holistic lens of an individual with many facets to my identities. They might be wondering, why didn't my pharmacist answer my questions if we're cutting them off or not asking open-ended questions when we're communicating? They might be wondering around trust of the pharmacist. Do they have my best interest at heart? Or even, does my pharmacist value what my health beliefs might be? Are they asking about my health beliefs? Or are they making assumptions because of implicit biases at play around what they think I want out of my care, for example? So kind of to dig further of how did this happen? How is it that we've gotten to this point in our lives that we've developed implicit biases in our subconscious minds? Well, if we think about bias as kind of a slow fog that we've been breathing in for many of our lives, we've culturally grown up in certain environments where media images, news images, conversations around our dinner tables, our education systems that we're part of have imprinted certain associations in our minds. So we might think of a particular type of patient when we think of sickle cell disease. We might think of a particular type of patient when we say heart failure. We're automatically starting to kind of think about, based off our contextual backgrounds and our experiences, or ideas that have been associated with certain racial groups or genders or certain socioeconomic class. You know, we are thinking these things in the background, even without consciously thinking about it when we're making decisions. These ideas have imprinted our ability to take action or make decisions objectively. So Dr. Hargis out of Harvard kind of put this in the context of the ladder of inference. So we're constantly through our senses, like we said, taking in millions of pieces of information or data points every minute. And when we see this data, we're adding cultural and personal imprints or associations to it. We're making assumptions off of this, we're drawing conclusions, we're adopting belief systems, and then we're making decisions or taking actions. And this is a reflexive loop that happens constantly in our lifetimes. And so this leads us to making knee-jerk reactions or judgments about individuals. So for example, a patient shows up late for an appointment or doesn't show up at all. We immediately might think, oh, well, that patient doesn't care about their health, or that patient doesn't want to engage in their care, when we don't think about objectively that maybe there's a cultural component to time. Time is not seen the same way around the world. Maybe being late is not seen as something that is negative by that patient, or maybe it was a suggestion to them to show up at 12 o'clock and they come in at 12:30. Or they might have an emergency going on in their family. And so they've not put a priority to their health that day. There's something more pressing happening in their lives. So it's important for us to recognize and realize with implicit biases, we want to move down the rungs of this ladder and try to be as objective as possible. Also to note that mental shortcuts are going to happen and are primed to occur more often when our time is limited in our day, when we have strong emotions present, because our amygdala, again, is firing with that fast thinking process, when we're asked to act very quickly or now, or we're asked to multitask, or we have to be very hyper-focused on a task. Now, I don't know about you, but in my practice setting as a pharmacist, this is pretty much every minute of my day. You know, I'm pressed for time, I'm multitasking, I'm being told to be very careful in what I'm doing. And so I'm going to be defaulting to my system one thinking because of these mental shortcuts needing to be activated in order to get my tasks and responsibilities accomplished. Let me give you an example of the hyperfocus with implicit bias in the medical literature. So in this study, Dr. Drew and colleagues out of MIT sent a series of CT scans to 24 radiologists around the United States. And they asked these radiologists to look for lung nodules that might be cancerous. Now, we're pharmacists, many of us are not trained to look at scans like this, but you might be noticing automatically there's something odd here. And what the investigators did in this study is they imprinted on the last slide of the CT scans a large gorilla. And this gorilla is 48 times larger than the average lung nodule that might be found. Now, in the final read that was sent back by the radiologist to the investigators, 83% of the radiologists completely missed this gorilla. Now, these are radiologists that were trained in many different centers. It wasn't about their competency level. It was the idea that they were primed to look for something. They were told to look for lung nodules, not for gorillas. And so their brains were automatically filtering for what they wanted to see. Now imagine this same idea as pharmacists in the task that we're asked to do every day. We think about medication safety, when we think about looking for errors, we are looking for what we want to see often, and we might be missing other things. And so this could be detrimental when we think about inequities that might play out in healthcare. Implicit biases can lead to health disparities through many different pathways. The literature has shown that this could lead to misjudgments and decisions about patient care because, again, of that filtering that we're doing through our unconscious minds, miscommunication and mistrust that could develop between the pharmacist or provider and the patient. And that could lead to a patient wanting to disengage from their treatment plans, not want to be as adherent because they're not, again, feeling like they're being seen, heard, understood for themselves. I think when we think about health disparities, it's also really important for us to root to what the definition of health disparities are. So health disparities are just a rate, right? They're a number, and the difference in illness or disease or conditions between different populations. And these can be based off of race, ethnicity, disability, gender, expression, sexual orientation, income levels, where people might live, rural or urban, and many other categories. But when we think about health disparities, and these are just, again, rates, right? So in the United States, we often tout these rates. We'll say certain groups are higher rate of having diabetes or stroke or heart disease. We have to look beyond the rate or the number, and we have to start to dissect, why is this happening to certain groups? Who is at most risk for these health disparities? And when we really look at some of these categories of patients, we'll note that often these are the most vulnerable and marginalized populations around the world. Individuals that might have disabilities, individuals that might have housing insecurity, individuals that might have had criminal histories and have stigma around them, individuals that might not speak the primary language in a certain region, and many other categories, as you can see here. So what I often talk to other providers that I teach in my workshops is to recognize that we should be even more vigilant around looking for our biases when we are managing the care for vulnerable populations in these categories. The consequences are pretty dire when we think about how these health disparities occur. When we think about that, often the literature has showed us under treatment of very chronic prevalent disease states with these populations, everything from cardiovascular disease, mental health, diabetes management, that this leads often to negative interactions, like we've mentioned, with patients, mistrust occurring between the patient and the provider. And then again, these health inequities or unequal care because they are disadvantaged already historically in our populations. Again, the disparities often are seen in the literature in diagnosis and treatment. So these are just some examples from the literature in the United States that we've seen, Hispanic or Latinx patients not being given as much pain medication when they're coming in to the emergency department with fractures. We've seen our Black patients not being referred for cardiac catheterization compared to white patients, despite coming in with identical clinical presentations and lab information. And we've also seen ethnic minorities in the United States less likely to be provided preventative screening, for example, for cholesterol or blood pressure or diabetes compared to their white counterparts, because again, and these are just the numbers we're seeing, but then what's behind those numbers because of unequal care or assumptions or implicit biases at play by the providers that are caring for them. Again, the key term here is that these health disparities don't just happen. We shouldn't just take these numbers and say, well, this is just the way it is. We should take another oath to ourselves to say, we're going to try to unearth these and really get to the root of why these disparities happen for vulnerable populations. So we're going to move into the drivers of these health disparities at this time.
Thank you, Sally. So as Sally mentioned, these just don't happen. We need to start examining why are we here, what's causing this, what are our drivers for these health disparities. So something that we do know quite well about implicit bias is that it does impede communication between providers and patients. So that's a driver of disparity there. We don't quite know so much whether implicit bias does directly impact clinical decisions and outcomes, but we can, there is a lot of evidence to support that it does impede communication. This can lead to mistrust and negative past experiences, which Sally had mentioned earlier, and that kind of just feeds into this eternal loop of mistrust, bad experiences over and over. We need to consider social determinants of health. So someone's employment status, their socioeconomic status, their social class, all of those kinds of things. Intersectionality is becoming a big thing at the moment as well, which is where different parts that make up someone's identity cross over and contribute to the way that they experience disparities and inequalities. So a female presenting Black person may have different experiences in a particular culture to someone who's white and male presenting, for example, or even white and female presenting. Policy can also be a driver of health disparity, both at a national or even an institutional level. Policy is often made by people who are in positions of high standing, so they're often themselves not the minority group. They're not the people likely to be experiencing these disparities and these inequalities. In a similar note, there's also an underrepresentation of minority groups in the health workforce, and this can further blow out these health disparities that we see. We are in a COVID-19 session right now, so it would be amiss for us to not discuss some of the disparities that have come up during the pandemic. I think the pandemic is really kind of drawing attention and making some things really obvious in terms of where these disparities are evident. I am talking quite a bit about data from the US in these slides, and that's not to make this US centric. It's just that that data is the most kind of obvious and easily accessible to us. So in the UK and the US, we're seeing that Black, Asian, and Hispanic people are overrepresented in COVID-19 hospitalizations and deaths as well. For example, in the Chicago area from this statistic from April last year, African Americans make up 30% of the population in Chicago, but they accounted for 70% of the COVID-related deaths. So we're seeing, disparity as a rate, that is a significant difference between 30% population versus 70% of the total deaths. We're seeing there's not only just disparities in deaths, but also in testing. So there's been reports of Latinx and Black people in the US being offered less opportunity for testing, particularly in the early stages of the pandemic, diagnosis with COVID, and then of course also the treatment pathway that they are placed on to manage their COVID-19 infection. So we really do need better reporting and data availability across the globe to really assess the scale of what's happening. These examples are from the US, those are quite clear cut, but it would be really interesting to see this on a global scale as well. So the pandemic is exacerbating existing disparities. People already experiencing different levels of care, different disease states, and the pandemic is really just bringing that to light, putting the health system under pressure, putting individuals under pressure, and they're really becoming apparent. There's some of those social determinants of health I spoke about earlier, such as high-risk jobs, lower levels of insurance coverage, less accessibility to health services, mistrust of healthcare professionals from those previous negative encounters, housing density, and who knows, perhaps implicit bias. Increased disparities in managing other chronic conditions are also exacerbated. So it's not just that you're diagnosed with a COVID-19 infection and that is causing problems for your prognosis if you're one of these minority groups. It's even around access to telehealth and other ways that our healthcare has had to change as a result of the pandemic. These minority groups are being adversely affected by that as well. And it was actually flagged quite early by the CDC in the US that implicit bias could play a role in the management of COVID-19, and they explicitly called this out for healthcare professionals to be aware of. So of course, these may be provider-driven, patient-driven, institutional, and policy level. We don't have all of these answers. But we also need to consider, does our public health messaging meet the needs of minority groups and people who are most at risk? We should probably think for example, in Australia, certainly I can speak to that, and in the US as well, many policymakers are middle-class white people. Is that really serving the interests of the entire nation best? Then we've actually seen some interesting evidence that this could also extend to the uptake of public health measures. So that includes masks, vaccines, social distancing, and so on. It's quite interesting study that I found that in a few particular areas in the US, mask wearing, which early on in the pandemic was slowly adopted, was not found to increase until the rate of white deaths relative to Black and Hispanic deaths increased. So this was in non-mandated mask wearing areas. They were monitoring how many people were using face masks. And once the number of white people increased in deaths, that's when the uptake increased. And that's really interesting. Is this perhaps suggesting some kind of implicit bias towards the value of non-white lives? This is certainly becoming a big global topic, and organizations, including the World Health Organization, are starting to really get concerned about health disparities, and they know it's a major issue that we're facing on a global scale right now. So the theme for this year's World Health Day was building a fairer, healthier world. The WHO is really putting out a lot of material and a lot of policy and discussion in this area of health disparity and increasing health equity around the world. FIP, for those of you who have joined some of these webinars in the past, one of the development goals is around equity and equality, and that's divided into the sections of workforce, practice, and science. And FIP is really doing some great work. There we go. Thank you, Dahlia. I was waiting for you to pop that in there. Really doing some great work around increasing equity. And then this started off, I suppose, relatively focused around the role of women in the workforce and practice and science. It's really expanding now to think about all of those different areas where we're seeing inequity. Finally, it's also the pharmacist oath. So I know that the American Pharmacists Association has a version of this, and there's probably a few versions around the world, but the FIP one, which was adopted at Congress in Bangkok in 2014, explicitly states, "I shall treat all those I serve equally, fairly, and with respect, regardless of gender, race, ethnicity, religion, culture, or political beliefs." So when we take that oath, we think about our role as a health professional, we really do need to have that in the front of our mind, because we have these implicit biases that are firing discreetly in the back of our mind. If this is what we really aim to do, we need to think about it and bring it to the front of our mind so that we can make sure that we do treat everyone fairly.
Thank you so much, Jack. So as we kind of move into the second half of this session, we want to kind of leave you with some good news that implicit biases are very malleable. We can actually move ourselves from a place of not understanding them to a place of, recognizing them, being aware of them, and then maybe relearning. So our brains are very malleable, although we all have implicit biases. We are not immune to implicit biases. We know they don't outwardly align with our value systems or belief systems. And again, we can unlearn these. So how do we do this? How do we move to a place of strategy around it? So we're going to talk about mitigating bias and bias intervention at this time. Often I find during these sessions and workshops, individuals, understand the problem, but then they want solutions. We want to know how to get there. And I'll preface by saying that when we're mitigating or trying to reduce our own implicit biases, it's not going to happen overnight. I often say, I've been teaching around and researching implicit bias for over 6 years now, and I still wake up every morning with implicit biases, right? So it is something that we have to, work at every single day. The first point is to say that it's not about being blind to our differences, whatever those differences might be. Actually, one thing we know, differences make this world really interesting to live in, right? If we were all very homogenous or there was a monolith of all of us, it would be very boring to work in this world. But beyond that is that when the knee-jerk reaction is to say, well, I don't see color, I don't care about gender, I don't care about, I don't see these things, I'm fair to everyone the same way, that actually can be really harmful, because differences are often where marginalization is rooted. When we ignore our differences, we actually end up ignoring where biases are surfacing, and that further perpetuates inequities. Because the point of it being, as we saw from the neuroscience, is that it is almost impossible as humans to be completely neutral and objective in every facet of our workday. We have values, we have beliefs, we bring those to our workplaces. We don't check them at the door of the hospital or the institutions where we work. So these implicit biases are ever present. What the goal should be is that we're constantly monitoring for them, that we are making sure that we're checking ourselves if some of these biases might surface. And as healthcare professionals, we are mindful of how we're approaching individuals around us and communicating with individuals around us, again, beyond just our patients, but our colleagues as well, so that we aren't contributing to prejudiced thoughts or stereotypes that are already kind of normative in our cultural environments. Biases you can think of as habits, right? And habits take 20 to 30 days often to break. And so what conditions are needed from the literature that we've seen to counteract these implicit biases? The first part is acknowledging, not denying, that we all harbor unconscious biases and that we have an organic desire or motivation to want to change them, that we're providing attention to any stereotypical responses or assumptions that might be activated in our minds, and that we're going to dedicate ourselves to practicing strategies that we'll be talking about today that actually reassociate automatic assumptions that we have or associations that we have from our learned experiences. So we're going to talk about 6 different strategies from the literature. And Dr. Devine and colleagues offered these strategies through some studies that they did around healthcare education. And so, this is stuff that I always say, pick one and start there. If you woke up tomorrow and said, I really want to work on myself with regards to implicit bias, listen to the next 6 and kind of think about which ones would be the ones that you would want to pick for the next week, and then maybe add on a second one the second week. But the first one is perspective taking. So perspective taking is really this idea of empathy, right? Putting yourself in the other person's shoes, adopting the perspective of often a marginalized or stigmatized group or individual. And this strategy is really useful when we think about assessing the emotional impact that might occur to individuals that are often stereotyped in our environments in negative ways. So really listening to them, understanding their lived experiencing, asking questions before we assume we know what it's like for them to live their lives. The second is partnership building. So this is really setting a mindset, especially in patient care, that we are collaborators, we are partners with our patients, that we remove any sort of power dynamics or power discrepancies and say that, I'm the pharmacist, I might have a social status, right, as a pharmacist in this environment, but I'm not going to use that over you as my patient. I'm going to look at you as an equal in this decision making. And the same can be said when we're collaborating with our students, right? Often there's dynamics of power there between a professor and their trainee, or a pharmacist and their apprentice. We have to kind of, again, equalize that so that we can see that we're not perpetuating power dynamics that might actually further perpetuate inequities in care. The third is engaging with others. And this is really the idea of increasing consciously our opportunities for positive connections and positive, seeking out people that might not be those that we often seek out. So I want you to reflect about who you eat lunch with most days. who is in your social circle? Who are your friends? Often we find as humans, we gravitate towards others that are very familiar to us. We have a lot of common interests with, we align with our viewpoints on, and that's fine. But what often happens when we do that over and over again is that we limit ourselves from really understanding people that might be from other groups, social groups around us. And that might contribute to even how we might treat others in our workplaces. So I always tell people, if you work in a setting or part of a city or a region where you can go into different grocery stores that maybe you haven't been to that service a different population than you might be familiar with, observe what kind of foods are being eaten, observe what kind of conversations are occurring, get even on social media. Think about who you follow on Twitter, who you follow on your different platforms. It's usually like-minded individuals. Have you considered following people that might have a different viewpoint to you? And it's not to say that we have to accept those viewpoints, right? But to just say, I'm here to understand. I'm here to try to respect your viewpoint, just like I would want you to respect mine. So engaging with others is a really powerful tool to reassociations when it comes to implicit bias. The fourth one is stereotype replacement. So this is where we recognize that often we have an immediate response to a situation or a person in a very stereotypical fashion. And so the goal here is that we're actually substituting our biased response for an unbiased one. So for example, if you're caring for a patient who might be 80 years old, flip the script and ask yourself, if this was a 30-year-old patient with the same disease state, same issues, how would I feel? Would I have the same reaction to them? Or flip the ethnicity, flip the gender. If this was a male patient instead of a female patient, would I feel the same way? Would I come to the same conclusion? And that usually will catch us in the act of often having stereotypical responses. Counter-stereotyping imaging is very kind of similar to that, right? So this is where we're detecting our stereotypical response and visualizing someone. And sometimes with counter-stereotypic imaging, it's actually someone that we look up to, someone we admire in the public eye. So someone that might be opposite. So we're trying to combat our confirmation bias around a particular individual or identity that that person carries. And the last one is individuation. So this is really where we're seeking to look at an individual as a person, a human before the patient. I like to see this play out often when we say, my diabetic patient. When we say diabetic patient, what we're doing is we're leading with the disease state. We're kind of labeling that human as a disease state rather than saying my patient with diabetes. Right? Very different tone to that we might not even realize. When we say my patient, we honor the fact that this person has many other facets to them. It's not just about their diabetes. We're not just looking at them as diabetes anymore. And so this is a way that we, can really look at the person. There's been studies around this with counter-biasing where physicians have actually asked patients about their lives before they've asked about their symptoms. So they've said, tell me about your favorite food. Tell me about a place you like to vacation. Tell me about your family before they ask them about what are your symptoms, what brought you here, tell me about your past medical history. Because again, you humanize the person in front of you, and then you start to see them in a different light than you would if you went straight into the disease state, which we often are socialized to do in our training. So this has become really important in our training of our students around the world also. Dr. Avant is one of the leaders in implicit bias education for pharmacy learners in the United States, and she's done a lot of great studies that I highly recommend you look into if you happen to be a faculty member or have influence of teaching in any training programs around the world, because she's really shown some good examples of using coursework and curricula to enhance the input of implicit bias training as we kind of push for more health equity work in and cultural competency focus in our pharmacy education. So this is a really great study that she did a few years ago that looked at an elective course that tried to change the minds or at least bring awareness to implicit bias for pharmacy trainees. So as we think about employing some of these strategies, I want you again to think about this as a slow and methodical process, a process where we have to be mindful, a process that's going to take some time, and it's going to feel a little uncomfortable, and we have to embrace that discomfort. So if you at the beginning of the hour were an individual that switched over your ring or watch, how did that feel for you? Maybe your attention came and went to that watch or ring or bracelet because it felt a little different, right? And that's the feeling that I want you to kind of capture as you think about using some of these debiasing strategies, being more conscious of these strategies and employing them, because it's going to feel slightly uncomfortable. It's different than what we usually do, right? But that's also that stretch zone. That's that place where we start to learn. And it doesn't matter how many years you've been in practice, how senior you may be, how many leadership positions you may have held. Everyone carries with them these unconscious biases that are needing to be kind of looked at and focused on in order for us to, again, be fair and impartial in our treatment of patients. So this is going to move us into our activity time. So I'm going to pass it back to Jack to guide us through this activity.
Thanks very much, Sally. So we're going to have a turn now at looking at our own biases. So as Sally's gone through, an important step in tackling implicit bias is finding out what our own biases are. And how do we measure something that's implicit? And this is like a really good question. It's quite challenging. You can't ask someone about their implicit biases simply because of their nature. So there's several different tools that have been developed. The most sort of famous or infamous is the Harvard Implicit Association Test. Obviously, no single tool is perfect, and it's a bit of an oversimplification of the concept. But this is probably the most widely implemented and most widely tested tool. So we're going to get you to have a turn of this today. So on your own devices, we're going to get you to jump onto the website. Thank you. Or you can use the QR code if you'd like to take it on a mobile device. What I will just flag as a bit of a caveat is that if English is not your first language, there are several options to take it in a different language. Certainly, I know French and Spanish are there. If you would like to try and see if it is available in a different language, please use a desktop device to access the website. On your mobile device, you will only be able to access the US version. So if you use a desktop site, you'll see that there's a few different countries and a few culturally specific versions that have been created. It's pretty self-explanatory. I won't give you too much of a heads up of how it works. It will pretty much tell you what you need to do. If you think about it too much before you go in there, it might affect the way that you answer. At the end of whatever test you happen to choose, it will ask you to input some demographic details. Please feel free to scroll to the bottom of the page and bypass that. You do not need to enter any of your information to get your results. So please don't feel obligated to fill that in. And we're going to have a little bit of awkward silence, perhaps for a few minutes, while we give everyone maybe 5 to 10 minutes to have a go at taking one of the tests. And then we'll have a little bit of a debrief. So please fill in, maybe choose one that you find interesting. There's usually a range depending on which region you've chosen. And we'll leave you to do that. So a little bit of silence while you're doing, and then we'll reconvene. I'll probably give you about a minute warning before we're going to come back together for a debrief so you can finish up. We are still here on the chat and Q&A box, of course, if you do wish to engage with us while this is happening. Okay, everyone, we'll have about another 60 seconds or so before we'll wrap up and come back together to debrief. So please finish up your test that you're taking if you have the opportunity to in the next 60 seconds. Okay, thanks everyone. I hope you managed to get through a test or maybe even two if you're speedy in that time frame. So we're going to have a little bit of reflection now. Think about how the results made you feel based on what the test told you. Did your results surprise you? And had you ever considered your own biases prior to taking that test? So I know the first time I did an IAT a few years ago, I did one particular one. I thought, oh, there's no way that I'm biased. Like my explicit biases are actively, that those two groups are the same. And of course, the result that I ended up with did not match that at all. So I am curious to see if that was kind of a common experience for anyone else. So using the Zoom chat feature, perhaps just type in one word on how your results to the IAT made you feel. First word that comes to mind. Okay, good to hear. We've got relieved, aware, some people are saying they're expected. That's interesting. A little bit anxious, perhaps. Excellent. Okay. It's interesting. It's when we look at the studies that have been done with medical practitioners in particular, surprising, yeah. Anger is actually an outrage is quite a common response to this. You know, this stupid test, it doesn't work. I'm not racist. I'm not sexist. I'm not whatever. It's really interesting to see when you do it. So if you do have time later and you're interested, feel free to take another test or two. Now that you know the format and how it works, I think the first one is always perhaps the most accurate because you are like, oh, I don't know how this works. So it penalizes you for taking longer time to answer. So the quicker you are, because obviously those implicit biases are quick firing. We don't want your brain to pause and think. Yeah, take another couple and see how you go. It's quite interesting. So I'm glad that some of you managed to get through a test in this time. And if this was your first experience of doing the test, I hope you found that. Perhaps not, I don't know if enjoyable is the right word, but that you found it interesting. Perhaps you did find it enjoyable.
Yes, and I think another reflection point is which test did you pick if you had options? I think that says something about where we're curious, or maybe where some of us might have said, oh, I got the expected results because I selected a category that maybe I've done some work around, or I've read a lot more around, and I've done some debiasing strategies around. So I think that also in itself says some things that we can reflect on. I think one of the things we want to leave you with is that this session really was about planting seeds. It is, again, not meant that we're going to walk away from one session on implicit bias and be cured or not have any implicit biases anymore. It's really about saying, let's get curious. Let's lean into that curiosity. Let's disarm any sort of defensiveness if we have any around it, and let's learn more. And so knowing more about your biases, these are a couple resources we wanted to share with you. The Ohio State University has a really great website full of amazing resources around mitigating bias in healthcare. And the Kirwan Institute is a think tank that has a lot of tools as well when it comes to bias intervention, for example, strategies you can use around microaggressions that come up in your work environment. So if you want to explore some of these, even with your students or colleagues, I know that some institutions have had kind of lunch and learns where people get together and we'll discuss an article from some of these resources and have just a healthy discussion around it. So we encourage you to keep the conversation going. And like we said, disrupting our biases is really about auditing ourselves and routinely and honestly being reflective and asking ourselves, what biases might I have? What biases might be surfacing towards this patient or person that I'm interacting with? Moving away from denial, saying this is not about being a good person or a bad person. This is really about saying, I'm going to get a little uncomfortable here. This is part of the process. And it's not about perfection. It's about the point that we all have this common goal that we want to cultivate environments of belonging. We want to cultivate connection and community with our colleagues, with our patients, and addressing implicit biases is a direct pathway to that. And like we said, it's not about shaming one another. It's not about pointing and blaming one another. It's about saying, our goal is awareness and acknowledgement so that we can move forward and promote more equitable care in our environment. So our key takeaways today is really, again, that no one's immune to having implicit biases. Becoming aware of them and unlearning them is our goal. Getting uncomfortable before we can get comfortable is key. And that unbiasing techniques, although they might be a little daunting initially to start practicing, are going to be the key to connecting with our patients and one another. So with that, we're going to move into our Q&A portion of the program.
All righty, excellent. Thank you very much, Jack and Sally. This was wonderful, and I did enjoy it, and I'm sure everyone did. All right, so a few questions we had from the audience. So the first question is for Jack, and I think it might have to do with some of the methodological choices with implicit bias, some of the things with your study. So if you could please very briefly, so that we can take as many questions as we can, highlight that.
Sure, thank you, Mahad. Quick fire round. Thank you, Carolyn, for that question. So I suppose it's complicated to explain a study in the 20 seconds I have on the slide. Essentially, we audio recorded the conversations between the actors and the pharmacists in the pharmacy. So as I said, this was covert and the pharmacist didn't know that. The tone was done through discourse analysis. So we also worked with a social scientist who has a lot of experience in that field working on those audio recordings. And the tone was perhaps less so just a verbal tone as to how we would tend to think of it, and more an overall discursive tone. So were they caring? Were they abrupt? That's kind of what we were looking for. And I suppose like that, you raise a valid question. How can we be sure it's implicit bias? The answer is we can't. So that was the approach we took. It's certainly exploratory. There's plenty of other avenues that we can improve on in that study. But in terms of the first study to look at implicit bias in pharmacists, I think it was a pretty cool approach. It was pretty exciting work for me to do as a PhD student. So yeah.
Awesome. Thank you, Jack. And I understand that, as a researcher, it's really hard to get these questions at such a short time. So thank you for addressing this. Sally, a question for you, and to my understanding, it relates to diversification and having diversity in providers, and what impact would that might have on issues of bias, implicit bias?
Yeah, that's a really great question. I think Jack alluded to the fact that one of our major global goals is really diversifying the workforce. And this is really applicable to many areas of the world. And when we think about diversity in itself, what that brings is perspectives, right? And we're not just talking about racial or ethnic diversity. We're talking about all parts of identity when we think about where people grew up, where we think about belief systems or religions, we think about sexual orientation. You know, these are things that change kind of our perspective of how we look at our practice models. It provides education for one another. And so I think it's always a best practice to really look around the table at your workplaces and say, who's here? Right? Like, who have we hired? Does everyone kind of look alike, think alike? Are we really being diverse in our hiring practices? And make it a kind of a metric that is something that we work on. I think part of this is also community engagement. So maybe you're limited in your workforce hiring capabilities for diversification, but thinking about when you're creating interventions for a community. This is kind of a public health concept, right? That you're engaging the community as part of the decision-making process. You're bringing in members of that community to talk about what policies you're developing, what interventions you want to make for care for that population, so that you're not kind of moving into this as a savioristic process where we're saying we know more than you do about your lived experience. So that's another kind of tactic to think about when you're in a position where you're creating policies or medical interventions for patients.
Alrighty, thank you, Sally. Now moving to another question that Jack will be taking. So an interesting question or comment. So can bias be positive in some situation? And one of the participants is sharing an experience that she had with people of different occupations. So would you be willing to share your thoughts with us on this, Jack, please?
Yeah, I mean, so we obviously, in this session in particular, we've painted that maybe the more negative aspects of bias and the disparities that can potentiate from that. I suppose bias may not always necessarily be bad, but I think we should try and be a little bit more objective where we can. So in this instance, we talk about the example that was posed to us was two different people coming in for pain relief. One person has a job which may have involved more physical labor. The other person has a job which may involve less physical labor. So therefore their pain tolerance may be different. I think that's a bias, and also it's actually an assumption. So that's maybe even less so implicit and perhaps more an explicit bias. I think a way to combat that is to actually take objective measures when we're speaking to people. So in this case, for pain relief, we use a pain scale. What's their history of pain relief use? Have they ever used opioids? What's the nature of the pain, if we're taking this pain example? So I think we have those assumptions, and this is kind of a good example of where we think our brain trains us when we make these assumptions, and it turns out for the best that we keep making the same assumptions because we've had a favorable response to that in the past. So I think it's about trying to take a step back, slow down, and get objective information so that we can make a clear clinical decision based on what's in front of us, not making assumptions about our past experiences.
Interesting. All right. Question for both of you from one of our attendees. So if we have people with diabetes and so on, and then if you have people with multiple comorbidities, so what would you choose to call them? What would be a reasonable way of?
I think this is very interesting. Perhaps we might pose if we need to always label our patients with what disease states they're living with. We should really try and take a person-centric approach to looking after our patients, and also their preference. Some people may like being called a diabetic. I don't know, that's an individual choice. So think about the patient and what their preferences and their experience might dictate in that sense. I don't think there's strictly a right or wrong answer. There's lots of cultural things to consider as well.
How about we have Sally take the last question? So I think it might relate to ethnocentrism a bit, not sure about that. So how would you differentiate your value and belief and biases if some individual have their own set of beliefs which others may view as biases. So do you have thoughts you want to share on this, Sally?
Yeah, this is a really complicated question for sure, because we do have values and beliefs, right? We are socialized to have these. They make up who we are. Often they might influence how, again, we behave, what decisions we make, even around our career choices. And so I think it's the first point of that is saying, have we sat and thought about that? And then where's our line? And that's going to differ from person to person, is where, I'll give you an example. I'm a Muslim. Growing up in the Western world, that was something that was always a marginalized identity that I had at the front part of my mind, because I had to think about my diet. I had to think about religious practices, not aligning with the dominant culture around me. And so I've had to make decisions and pivot points at certain parts of my life where maybe parts of my job or parts of practice that were expected of me did not align with my personal values and belief systems. And often that can be intimidating when you're a marginalized group in a particular environment. So it takes some bravery, it takes some reflection of how does this play out? And could it be impeding my ability to be objective sometimes? So it's a very complicated, great question. Often when we think about bias work, we also do a lot of social identity work in the diversity equity space, because it's important for us to sit with ourselves first and kind of say, how am I perceiving the world around me based off of my different parts of my identity? And how can those intersect with my job and my decision points that I'm making constantly? And so, it's a very personalized approach. I'm not sure if I'm answering the question exactly, because it's a hard question to just say there's one way to do it, right? I think it's about first recognizing what are your values and beliefs, and could they be promoting biases? Could they just be honoring who you are in your identity, and which is okay, right, as well.
Thank you for sharing your thoughts on this, Sally. I really like with how the structure you're putting. So starting with reflecting on what are my beliefs, how are they impacting me, and sharing some of your personal experience. So thank you for that. So if we can have time to one really quick question before we wrap up. So now that I attended, so I'm putting ourselves into the attendee shoes now. I attended that session, like that session. How do I spread this message in my institution? So perhaps if you can have Jack share his thoughts on this, where to start with that.
Yeah, I think you don't want to be confrontational about it, I suppose. So trying to take a positive approach. You can't really just walk up to your institution perhaps and say, we all have these awful biases and you need to do something about it. So I think the webinar makes a great conversation starter. If you're speaking to your colleagues, you can say, I attended this really interesting, hopefully, webinar. This is what we talked about, and just starting that conversation and broaching the topic with people gently. I don't think pointing fingers, we really don't want to leave this session going, you're all awful because you have biases. That is not at all what we're trying to say. It's about how do we start to acknowledge them, start the talk about it, get comfortable with ourselves. So I think perhaps looking at yourself when you walk away from the webinar is a really easy place to start. Taking some more of those IATs, thinking about some of your own biases. Sally, did you have anything you wanted to add there?
Yeah, no, I echo what Jack just mentioned. And I would say starting with curiosity. I think all of this starts with curiosity about ourselves, curiosity around what might be going on in our workplaces. So asking more questions before we jump into solutions. I think we often are, in healthcare socialized to how do I fix this? How do I fix this? What's the solution? And we have to kind of get away from that mindset when we're talking about bias and health equity and start with just asking why. Why do I think this about this particular group? Where did that come from? And exploring that. Why do we practice this way? And sometimes that makes people uncomfortable, especially often leaders who are like, well, this is just the way we've always done it. And I think that answer is very knee-jerk, right? We just want to say, oh, well, this is just how we do it. But why do we do it this way? Could that be leaving certain groups of patients or certain employees on the fringes? Could that be contributing to them not having the same opportunities, the same resources, the same chances as everyone else? These are hard questions to ask, but I think that's a starting point.
All righty, excellent. Thank you very much, Sally and Jack. Really appreciate you taking these questions, and I enjoyed your presentation. I can tell a lot of people loved it too. Now it's moving to wrap up, so I want to sincerely thank our panelists, Jack and Sally, and facilitator, Dr. Dalia Badges from FIP. The recording of this episode will be made available on fip.org and on the YouTube side. Please give your feedback to FIP at webinars@fip.org so we may continue to improve our digital event offerings. Thank you very much and good day to you all.
Goodbye, everyone.
Thank you, everyone.
Thank you.
Right on time, 3:30.